Thank you so much. Hi, everybody. Thank you so much for coming on a cloudy, cold Monday afternoon. I very much appreciate it. So I am going to get right into it and start talking about it. So I am starting with the expectation that, there we go, that not a lot of you know maybe what ethics is or how it connects to medical AI or how it connects to research. So we're going to do just like a broad 101. We can obviously spend an entire year or years talking about ethics and what that means. But I'm going to give you just a rough draft, pretending you are all first year freshman students who just need to know the basics. Tell me what you're talking about. And then we'll get into a little bit about medical AI and the ethics of medical AI. So where I stem from is really this idea of, try and this so you can all see it, the 4 principles of biomedical ethics. And this is what really guides our practice as healthcare ethicists, as bioethics scholars. It's really the foundation of what we mean when we talk about ethics. So I'm going to go into each one, but the 4 are autonomy, beneficence, non-malfeasance, and justice. So autonomy, right? I'm sure many of you know what that means. So very briefly, it means self-determination. So the idea is that we acknowledge that person's right to hold views, to make choices, and to take action based on personal values and beliefs. So if you are at the doctor's office and the doctor asks if you want an X-ray or an MRI, right, and gives you that whole long form that you glaze over and sign at the bottom, that is you self-determining, that you are consenting to have that process being done. So that's like what we like to talk about when we think about autonomy. When we think about research, we're talking about that idea of voluntary participation. So that idea that when a researcher gives you a survey or asks if you want to participate in an interview and you say yes, and they give you this long consent form that you right glaze over and then sign at the bottom, that is voluntary participating. There's no conflict of interest. There's no undue coercion. So many of you who might be doing research may wrestle with, well, how much of an honorarium do I provide to my participants, right? How much money should I give them for their time? That is because we are balancing participation with undue coercion. We don't want to provide them with so much money that they feel that that is coercing them to participate in research. So one of those questions is actually an ethical question of what determines an honorarium or a participant incentive. The second is informed consent, kind of like what I talked about in that doctor's office, right? Does a patient or a participant have the capacity to consent? So do they understand, right, those pros, those benefits, the risks, the limitations? Do they understand their responsibilities of their participation as a participant or a patient, and that of the researcher? You also have to understand the responsibilities of the researcher. What does the researcher owe you? What have they promised you? What are they going to provide for you? You're able to balance the risks and benefits, and then you're able to understand confidentiality, privacy, data storage processes. And we can talk about data storage after if you have questions around it, but that's also a really ethical concern because you may or may not know that many of data storage software have terms of use. Many of them share that information with third parties. What kind of information are you asking about your participants or your patients? And who has access to that? Can you guarantee confidentiality when we are working online, when we're working on the cloud, when we're doing interviews over Zoom or WhatsApp? Those are really hard questions to navigate. But then we get into beneficence. These are forms of action intended to benefit other persons. So when you do research or you're a physician, you want to know that you are benefiting that other person. And it doesn't have to just be protect the individual person from harm, but you have to think about social or health value, your desired outcomes. You want to maximize the benefits while reducing the risks. If you guys are researchers, you all know that there's no perfect research. Every research we do has risks, right? Everything that we do, even if we're going to be physicians, it comes with risks. But when we think about the ethics of research and the ethics of healthcare, what we want to do is maximize those benefits and minimize those risks. We are ensuring that favorable risk-benefit ratio, and we're thinking about it to the individuals, but also to the community, to the populations that we want to serve, and to scholarship at large. When we are participating in research, we are stewards of scholarship. If we have funding, a body of research like the NIH or the NSF have given us money to conduct ethical research. And we have the autonomy to do kind of whatever research we want, but we have to practice in good faith. the scholarship, right? And that's making sure that our data is ethical, that our questions are ethical, and that our analysis and coding, whatever that means, is ethical. Because other people, right, the purpose of research is to replicate and reproduce, right? So people rely on us to do that ethical work. So this is from the common rule of what we want to think about when we think about beneficence is harm or discomfort is not greater than that ordinarily encountered in daily life during routine physical or psychological examinations or tests. So when you're doing research, you may not be able to not ask a really emotionally sensitive question, right? You might want to get at people's experiences. What are their experiences living with cancer, right? What are their experiences living with Alzheimer's disease? That might be really distressful. That might raise questions of discomfort and unease. That's okay, so long as it's not greater than that daily life. And think about ways that you are going to maximize the benefit and minimize the harm. And that's where we're going to get into non-malfeasance, which is the obligation not to inflict harm intentionally. Some people also say non-maleficence. So I just want to say, if you hear it both ways, it's kind of the same. So there's different ones about not to inflict harm intentionally. Oftentimes when we work with physicians or in science labs or things like that, we might think of physical risks, right? Those side effects of getting a drug, of getting a blood test, of doing a stress test, right? That bodily contact, falls, things like that. But as researchers, we also have to think about psychological, emotional risks, social risks, so loss of status, privacy or reputation, and the last one says legal risks. Know that your research could be subpoenaed. What does that mean? If you have data that's stored under the Patriot Act, what does that mean for your participants? What are your legal obligations? I'm in social work. Do I have a duty to report if a research participant discloses one of my fundamentals that I need to report, which a lot of the time is harm to self or others or child abuse or neglect? There are certain things, right? There are certain legal risks that come with the research that we do, and we need to be aware of those. So when we start thinking about AI, know that there are legal regulations surrounding AI. Dr. Tang just told me today that the White House just put out something, a white paper on it, right? There are certain legal stipulations surrounding that we need to be aware of. And that actually impacts the research that we do. Because if your work is subpoenaed, what does that mean for your participants? So some examples that I have are anonymity, right? Or is your participant data anonymous? Notions around privacy, that's person-centered, versus confidentiality, that's data-centered. So where you're storing your data, who has access to your data, safeguards and procedures, limitations of confidentiality. It's okay if you have to tell your participants, I can't guarantee that your data is going to stay confidential, but they need to know where it's stored. They need to know those terms of use. Is the cloud that you're using, is the software that you're using based in Europe, based in the UK? What are their rules, right? Because of AI and because of ML and because of the cloud and all the software that is happening online, we actually sometimes don't know where the data is being stored. We're like, I'm just gonna put it on the Google Drive and hope for the best, right? Don't know if that's safe, right? Oh, it's on my encrypted computer. I'm only gonna access it on, this, but I'm gonna store it on the Google Drive because that's just easier than Dropbox. Okay, those are participant information, right? And how are you gonna protect your participants? And then the last is justice. And this is gonna be kind of a main focus of my talk, being in social work. So I hope you will bear with me as I give a little bit of a social justice lens to AI. But this is where fair, equitable, and appropriate treatment in light of what is due are owed persons. So a lot of this is thinking through our research and how it impacts historically excluded groups, the fair distribution of benefits and burdens, to ensure equitable and culturally competent research. And at the end, I'm going to talk a little bit about what I mean by cultural competence, and that all populations are included in research design. Who is your research for? And so I'm a qualitative community-based researcher. I will put that out there. That was obvious from the outset of my talk. But we need to make sure that the populations that we want to include in our research are actually sitting at the table with us. And I'm going to talk a little bit about how that impacts with our notions of medical AI. So with all that said, in terms of justice, we often talk about vulnerability. And I kind of hate that word. There's a lot of different words. I use historically excluded populations when I think about vulnerability or marginalization, because I think it contextualizes it better. a lot of people of color, LGBTQIA+ populations, Latinx populations have been historically excluded from clinical trials, from healthcare decisions, from research, certain things that have been happening. And so I find that that's where I want to use it. But know that if you want to use minority populations or disadvantaged or underserved, those are other words that I sometimes see as well associated with it. But I'm intentional about historically excluded. So when we think about vulnerability in research, who are these populations that we're talking about? Sometimes it's susceptibility to coercion or exploitation, their increased risk of harm, maybe they have diminished autonomy, capacity to protect their own interests, historically excluded populations, so those who face systems of oppression, that balance the need for protection with benefits of access, knowledge, ownership, and protection. So what often happens when we deal with a vulnerable population, we say, we shouldn't have them in clinical trials. Nah, let's put them aside. And then what happens? There's no research on them. There's no information on them. And that actually impacts care. Certain conversations I've been having today are around, let's say, the COVID-19 vaccine. When historically excluded populations, let's say, for example, pregnant women, children at the beginning were excluded, there was all this idea of, oh, you're vaccine hesitant. Oh, you're anti the vaccine. When really, it was just real questions from people with certain health literacy who didn't know what to do because there was no information provided about them. So when we're scared of the diminished autonomy, or we're scared of certain things that are happening, or we don't want to do it, what happens is we become paralyzed and then we exclude them. But then what happens is there's no information. And that actually impacts the care that they receive and how their perceptions, which I will get into this with the medical AI stuff, their perceptions about the health system in general and how they navigate their relationship with patients and providers. So again, I said this, but obviously I talked about pregnant women, but children are included in that. Those who have mental illness, LGBTQIA+, Indigenous populations, economically disadvantaged. There are always power differentials between researcher and subject. And as we'll start talking about with medical AI, there is a disconnect between AI developers, researchers, and then the actual physicians and patients, who are the actual users of that. And if there's no dialogue between them, if there's no conversation between them, those ethical concerns, those ethical issues are just going to mount and mount. And what I said before is there's always going to be ethical risks. There's always going to be ethical issues, especially around emerging technologies. But what we need to know is how to minimize those risks, not to say there can never be any risks. And I think that's sometimes where we fall into that trap of saying, well, now we need to figure out ways to prevent all of these ethical issues. We will not be able to do that with AI and ML. That is not something that I think at this point in time we are capable of doing, because for how many years we have conducted research, there are still research risks. But we need to have real conversations about ways that we can mitigate that and how to move forward. And so I said research, right? Research has come a long way. And I know that you're thinking about that IRB process. And if any of you are like PhD students or doing a master's thesis or even an undergrad thesis, who are like, the bane of my existence of just wanting to do research, right? But it comes from real awful things that have happened in our society, right? So the first time that we started actually talking about research ethics was the Nuremberg Code in 1947. And I apologize if this might be repetitive for some of you, but I think it's important to know where we've come from and where we are now. And so this obviously happened maybe from the word Nuremberg that you kind of picked up on, the Nazi experimentations on human subjects, right? And so when the Nuremberg Code came out, they talked about informed consent, an absence of coercion, and beneficence. And those were their three main things, their three main ethical principles that they wanted to make sure that everybody followed when they conducted research. It feels really minimal to reading that and being like, where is everything else? But remember that this was the first step in trying to create research ethics. Then in 1964, the Declaration of Helsinki came out from the World Medical Association. They tried to make it a little bit more concrete, a little bit more detailed. They had respect for the individual, right to self-determination, so that's autonomy, but they teased it out of it, the right to make informed decisions, and privacy and confidentiality. So even back in 1964, privacy and confidentiality were an issue. Now with AI and technology, think about how privacy and confidentiality is still an issue, but made even more complex by things that are happening within our society. Then in 1974, the National Research Act came out, and this was created by the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. This had guidelines for human subject research, and it oversaw and regulate medical experiments. So this was kind of the first time that IRBs started to come out, right? Because they needed to oversee it. They couldn't just say, these are some ethical principles that you needed to follow. They actually needed to oversee it and regulate it. And this was from the Office of Human Research Protections. So this actually started to have guidelines, why you need to fill out that informed consent, why you need to fill out very repetitive, lengthy forms that seem like you're repeating the same answer multiple times for somebody who's just going to glance at it and either approve it or not because of this, right? And then the BELMONT report came out in 1978. This was again separate, and this came out from the Tuskegee syphilis experiment. Won't go into this. Happy to talk about it after, but a very long, very unethical research experiment that happened predominantly in the South among African-American men. This became even more. So as you can see, these research ethics guidelines came out because we kept doing unethical research. And the issue is that even after all of these reports and all these guidelines, do you think there is no unethical research currently happening within our society? No, still happening, right? Still utilizing historically disadvantaged communities, still going through all that. And I'm going to talk a little bit about that when I talk about medical AI. But this got into the respect for persons, beneficence, and justice. So this is the first time that you actually see justice play a role in that because of Tuskegee. And then you have informed consent, assessment of risks and benefits, and selection of subjects. This is also the first time that you see selection of subjects, because obviously it goes back to undue coercion. For Tuskegee, they didn't know what they were becoming a part of. They didn't really consent. They had low health literacy. How are we going to purposefully and intentionally recruit participants and ensure they know what they are getting themselves into? And then hide results, right? So you know about clinical trials and not telling them about things. So how does this all connect to AI, right? I gave you like a small brief introduction. Let's get into AI in healthcare. So this is just a nice slide. I'm not going to get too much into it, mainly because I feel like I'm in the Institute of Data Science, and probably most of you are like way more experts at AI and ML than I am. But I wanted to introduce you to how it fits in healthcare, in case that's a little bit new for some of you. So there's the patient-centered approach, right? AI can assist high-quality care to patients, electronic healthcare reports, smartphone apps that offer home health solutions, right? Text here I didn't add, but those are things like, remember to take your pills, or tell me what your symptoms are today, right? Little reminders and things like that, that we've seen grow exponentially in the past few years. Then there's data-driven healthcare. So AI allows data compilation and for clinical purpose medical research and review. There was something just in the Atlantic, I think yesterday, on sepsis and a new AI ML algorithm that can detect if somebody's at risk for sepsis, because sepsis is one of the main killers of patients more recently. And if some of you are interested in it, feel free to email me and I can send you the link, but it's in the Atlantic. And it's talking about how it can actually create algorithms based on when patients get admitted to the hospital. And if they seem like they're at risk for sepsis, a note will pop up for the doctor that the doctor should know that they need to be on high alert for sepsis. So that's kind of like data-driven healthcare, where there's effective treatments based on patients' relevant health history data as well. Medical diagnostic and imaging, right? This is probably the main one that many of you are familiar with. AI can assist imaging, detecting and screening earlier, right, for serious heart and brain strokes, lesions, cancer, Alzheimer's, and dementia-related research, right? Lots of things are happening with imaging and being able to diagnose earlier and faster and more accurate. And then enhanced healthcare communication. AI-assisted apps aiding patients to chat with doctors, appointment bookings, right? How many of you go online and get your little form and it goes, ready to check in, and you check in online, right? You do it on your smartphone, it's super easy. Or you're like, now with COVID, I think you have to wait in a lot of parking lots sometimes to be let in, and they go, text here when you're here, and you text here, and somebody's like, come on in, or they call you 5 minutes later, or sometimes an hour later. depending on the doctor, right? Those are enhanced healthcare communication. It takes away all that calling and all that having to fill out forms when you get there to doing it online. And this kind of gives you just a different picture of kind of the same things that I was talking about, but direct patient management, telehealth, treatment outputs, diagnostic accuracy, point of care, all those type of things. And so what are some of the benefits before I get into all the ethical risks, right? Because there are benefits to AI. It's amazing what AI has been capable of doing for health. It reduces administrative tasks for physicians. It facilitates the workflow easier, that maybe physicians can have more time with patients, more time with families to sit and engage and talk. Accurate and earlier diagnoses and treatment options, reducing human error and bias. It can be used to predict risk factors, right? Say, hey, I put in your stuff in an algorithm and you're actually at high risk for diabetes. Let's work out a plan for preventative care, right? If any of you have done the 23andMe stuff, right? That can tell you your risk factor for certain things, and maybe you can change some lifestyle things. Maybe you get that PCP that you've been waiting on to try and book that physical that you need. It can obtain information about social contexts that influence care. There's a lot of apps out there now on transportation and bus routes to try and get people into community care clinics, to try and relate to what's their zip code and how am I going to get them to care, or where's the closest dialysis center for them. So that can become more personalized and value-driven care, which can potentially reach rural and remote communities through e-health platforms and telehealth. We saw this during COVID, right? So many health systems and institutions and organizations said, oh, no, we can never do this work online, right? No, it has to be in person. And suddenly COVID hit and they're like, we're online, like the next day. And you're like, oh, so you could have done this all online, right? Like very quickly did it become a reality. And so we've seen that happen. We've also seen apps for older adults and mobility issues, those people living with disabilities, right? We've seen AI that has really helped them to transform their social networks, to help them navigate their house, to help them do daily chores and daily tasks. AI is fantastic in a lot of ways. And these are a lot of the ethical benefits. But with these ethical benefits come risks. So these are a lot of the main ones that have come up in literature. And I'm just going to focus actually on 3 because I don't have years with all of you. But so there's obviously data ownership, right? Who has access, who owns the data, the right to ownership. There's things like data protection, data sharing, accuracy, right? Of those type of things, transparency. And I wrote to whom, right? So how is the transparency to AI for patients, for providers, for the researchers, right? The developers know what they're doing, but where's the transparency? There's bias. So even though it can reduce bias, there's also a risk of increased bias. Informed consent, trust, cost, accountability, and responsibility, right? Who's responsible if AI doesn't work? If AI makes a mistake, right? Legislation and regulation that we see. And so with my social justice lens, I'm going to focus on bias, trust, and fairness, and talk a little bit about what this means, and then end with our implications and what we can do. So the bias of medical AI, and I'm sure many of you have talked about this at length, but I'm going to try and break it down for you. So humans, right, AI algorithms, they're created by humans, right? Like humans kind of create that algorithm. Humans have implicit and explicit biases that filter into AI algorithms. If we use data sets, know that there's historical exclusion in clinical trials. So who's actually part of your data set? Is it a homogeneous group of individuals? Those who use biobanks, maybe for imaging and diagnostics, know that like the UK Biobank, which is like one of the biggest biobanks in the world, is actually, I think, 80 to 90% white, right? And it's predominantly male. So when you think about, oh, I'm going to use the biobank to create an algorithm to detect, let's say, Alzheimer's disease. Okay, that's cool, but your sample is predominantly white men. And actually, we see disparities, which I'm going to get into in a minute, but we see disparities in Alzheimer's and dementia-related disease, actually among African Americans. How are they going to play a role in this? How are we going to detect and, draw earlier and more accurate diagnoses if these individuals are actually not in the algorithm? And then if you have the developers who aren't aware of those implicit biases, are they actually asking those questions? Do they actually notice that there are missing samples of individuals? questions that are normative and do not consider the complex intersectional identities. So you can put all this algorithm together. Sure, you can come up with an earlier, more accurate diagnosis. But I have two questions for you. One is, it actually doesn't talk about health disparities among diverse populations. And actually, okay, you can talk about earlier diagnoses. And I'm not saying that AI needs to cure and treat health inequalities, but I am saying it misses out that intersectional lens of how people are complex, of why there's health disparities, of health inequity. You might have an earlier diagnosis, but what if that person has low health literacy? What if that person actually doesn't have a PCP? What if they don't have health insurance? So something about an AI, and then it goes back to what is your responsibility? You have all this bias of saying, oh, we did this. Well, how's that actually helping individual patients at the end of the day? What are we going to do with that information? I don't know if many of you know about 23andMe, but after some time, they actually had to put a disclaimer in saying you need to talk to your PCP about any of these, because people were getting all this information and then making determinations about changing their entire life based on this information that maybe was accurate and maybe wasn't really that accurate. Or it said you're at, a 2% risk for Alzheimer's, and they're like, oh my gosh, I have to do crossword puzzles every day, and it's like, and actually everybody's at like a 2% Alzheimer's, right? Like it's not something that you need to change everything, and they get worried and they WebMD things. Whose responsibility is that? But where is the bias when those people aren't being represented in the algorithms being created? So how will AI/ML integrate these experiences without prior knowledge of patients and what they need? And how do we then transition to applying these algorithms to diverse populations, to those who we need to serve? And I mentioned intersectional identities, and maybe some of you might know what intersectionality is, but again, I'm teaching this as a 101. So intersectionality is that individuals belong to multiple social categories and identities, right? We're not just one person. We have an interconnectedness of social categorizations, different races, classes, genders, sexual orientations, all here, right? Fertility, language, mental health, ability. And these overlapping experiences create experiences of discrimination and privilege for each and every one of us when we come into that provider's room, when we come into the health system. And so if there's bias in these algorithms from bias of humans, those biases are going to translate into that health system, into that patient room. And what I want to leave you kind of with, and this is not the end, but what I want to relate to you in case you haven't thought about social determinants of health, is that health disparities are driven by social and economic inequities. I'm not saying that algorithms need to solve this, but I am saying that when we put in an algorithm and we use AI to diagnose, we also have to recognize that it's not just about a diagnosis, that it's not just about I've early detected Alzheimer's or diabetes or cancer. It's figuring out then, what am I going to do with that? And who's responsible for that, but where are those biases in? Because an algorithm doesn't look into the implicit and explicit biases within our social context that drive health disparities. So this is just something that you can think about. I'm happy to share my slides with anybody who might want them afterwards. But we know that economy, neighborhood and physical environment, education, food, community, healthcare systems all drive health inequities. And these are just a couple of slides just to give you that. So this is percent of non-elderly adults with selected health conditions by race in 2018. As you can see, American Indians and Alaska Natives are highest, right? And then you can see that Black is next, right? And so you are seeing that people of color have selected health conditions, have health disparities. This is real. And to go back to my last slide, they're excluded from clinical trials, they're excluded from our algorithms. If they're excluded from the biobanks, how are we then meeting them what they need and where they're at? We are once again failing communities of color. When we think about systemic racism in healthcare, is AI going to drive that, right? And so this is also COVID-19 hospitalizations and death rates among EPIC patients. So these are the ones that were in EPIC, which is like the electronic health record, for those who might not know. Again, you can see the disparities. I don't want to pay a lot of attention to this, but I just want to draw some things that have been happening more recently. So with inherent biases related to algorithms, it may overlook diverse health-related experiences, social determinants of health, health disparities and health inequities, actual follow-up and preventative care. So you can diagnose earlier, but as I can get that person to their PCP when we know they don't have a PCP, because most underinsured people go to community care clinics or community hospitals. The complexities of care, right? It's not a single solution. I think that we know this maybe in this room, but I think we put a lot of onus on AI and ML to solve a lot of these health disparities. And I think they have a lot of great potential. But when we don't recognize that there's people who are missing and omitted from those things that we are creating, that creates complexity. Because then what we're doing is we're once again creating healthcare for white individuals. And we're once again reorienting the health system for predominantly white older men. And so we have to think about what that means when we're creating AI. Trust. So like I said in the ethical benefits, trust is a huge one, right? Trust, maybe it gets more time between the physician and the patient, but ultimately it might not. So bias of AI stems from the bias of providers sometimes, right? We know that historically excluded populations have distrust in the healthcare, fears of discrimination, avoidance of care. There's a lack of training and education among physicians. We know that LGBTQIA, so for those who might not know, that's lesbian, gay, bisexual, transgender, queer, intersex, and asexual persons. So just in case you didn't know that, I just wanted to make sure that that was clear because I've said it a few times. People of color, disabled persons, right? They avoid the health system because there is a distrust. And I want to focus on COVID, but like vaccine hesitancy, a main concern among people of being hesitant to get the vaccine was a distrust in healthcare and the historical mistreatment and exclusion in clinical trials. That has been seen time and time again in original empirical research that has come out of the difference between vaccine hesitancy and vaccine confidence. So will bias of AI further distrust in healthcare? We know that the physician-provider trust is key to preventative care. Trusting your provider and being able to be transparent, be honest, go to them when you're not feeling well and know that they will listen to you and heed you and understand you and take whatever you say into consideration, that is preventative care. If physicians are spending too much time relying on AI or AI takes over physician-patient relationship, that is going to affect negatively that physician-patient relationship. And that relationship is key to reducing health disparities, to getting people into preventative care, to getting them treatment sooner. And so two issues that really come up is AI may reduce provider autonomy, so it might lessen that relationship, right? As AI takes over, the physician steps back more, even though we want the physician to have more time, oftentimes they just let the AI do everything. And the bias of AI may alter distrust prior to the office visit. So like I said before, you get your smartphone and they're like, oh, you're ready to check in? And you're like, yeah, let me just ask these couple of questions and I'm going to answer them. What if that algorithm doesn't ask the right questions? What if they forget or don't ask because of the person who created that algorithm of your sexual orientation or gender identity? That LGBTQ+ person want to feel comfortable going to the visit if their first experience in that provider's relationship is an online questionnaire that leaves out their identity? If let's say, and this happened to somebody I know, they were checking into a doctor's visit and they were having trouble getting pregnant. And the first question was, are you pregnant? Because they were seeing a fertility specialist. And they said no. The algorithm didn't pick that up and started asking them all these intrusive questions about their pregnancy. What do you think that's going to do to that woman who's already struggling with infertility? And suddenly that algorithm makes a mistake. Suddenly there's a loss of trust. There's anger, there's resentment, there's sadness before they even walk into the doctor's office, right? What if they forget to do a check-in or don't do it properly and they get to the doctor's office and they're like, yeah, you didn't do the check-in, sorry. You're gonna have to fill out all these forms. And they're like, no, I did it. They're like, no, you didn't. But if you're an older adult and you just don't know how that works and you're not sure, but if you're blind, what do you do then, right? Is there another way that they can check you in? I'm sure you can just go there, right? And they would check you in orally and things like that. But there are certain things like that. So we think about AI and we think about, oh, this is going to increase trust and it's going to ease the workflow and make things burden. For whom? We always have to ask for whom. Because I think that we tend to say when we're able-bodied or we don't think about more minoritized populations, we might say, oh yeah, I checked in, it was super easy, went fast. What if those questions omit or neglect your personal identity? What if they don't ask the right questions based on your own intercepting identity? What if you can't access it because of your age or your ability or certain things like that? Suddenly, like I said again, and I'm just going to repeat it, before you walk into that office, there's already been a lack of trust because of those biases of algorithms. And so what I want to just say is that this has real ramifications for actual patients who are using this. And yet rarely do I see patients at the tables of AI developers, right? We don't. They're seen as an aftermath of, oh, my assumption, my bias is that this is going to really help populations. So this, again, COVID data, but I just wanted to get you a sense of what's going on. So Black Hispanic adults are most likely to want to wait and see before getting a COVID-19 vaccine, right? Because of trust, because they want to wait and see. Larger share of younger Hispanic adults express vaccine hesitancy. Again, this goes back to healthcare. If we really want to think about trust, if we really want to think about establishing communication, we need to actually consider what these algorithms are doing. So I want to ask yourselves as we move through this, how will medical AI impact the trustworthy relationships to strengthen preventative care? And how will AI ML consider the complex lived experiences of individuals? Because we know they're not just coming and being like, I really want that earlier diagnosis of cancer. Yes, that might help them. But then what's our responsibility afterwards? Right? What do we need to do? And that gets me into fairness in medical AI. There are two components of fairness that I want to talk about, and that connects to justice, right? And that equitable access. There's the healthcare setting, and then there's the individual. So who will have access to AI ML developments? We know they cost money. We know you need resources, right? We know we need systems. And yes, we saw during COVID that many people can get on and get those mobile apps and get electronic health records and get it together. What I worry about is those less resource hospital settings, those community hospitals that are predominantly utilized by historically excluded populations do not have those resources, may not have that funding, may not be as competitive as those large, highly resourced academic medical centers. As an ethicist, I was employed by Baylor College of Medicine. I was employed by Houston Methodist Hospital in the Texas Medical Center. Those are the hospitals that have resources. Those are the hospitals that can afford consultation ethicists, right? To go in and manage those things. An algorithm goes wrong, we can get in there and we can manage patient-physician disagreements, right? But what happens to those rural areas? What happens to those community hospitals that just don't have the resources to do that, are barely hanging on, and all their beds are at max capacity, or they're in fear of closing because we know many rural hospitals are shutting down. 1 out of 5 people use a community hospital. Are they going to have access to AI? And I'm not saying that they're not, but I am saying that these are questions that we have to have in the back of our mind when we continue to ask by whom and for whom when we think about healthcare AI. This was a 2021 Pew Research report. So this goes back to the individual. Many of us say everybody has a cell phone. Who doesn't have a cell phone? I don't have a cell phone, but well, I won't say because that'll age me. But like I haven't had a cell phone. Like I think I got my first one like in the middle of college. Like I think about the days when I used to be like, bye, I'm going out to like my parents, and like they had no way of like contacting me. And that feels like really alarming right now as like an older person. But anyways, 7% of Americans, that's 23 million people, do not use the internet. 23% do not have access to broadband connection at home. 27% do not own a laptop or a desktop. 44% of households with incomes below 30,000 do not have broadband. 40% of schools lack broadband connections. 60% of healthcare facilities outside metropolitan areas should also have that lack of broadband connections. When we think of AI, when we think about electronic health, mobile apps, what do we need? We need Wi-Fi. We need access to data. We need data plan, right? This is just who owns a smartphone and who has a laptop. Who has access to Wi-Fi? Who has an unlimited data plan? How much do those cost now? I mean, looked at your like Verizon or AT&T bill like recently, it's exorbitant, right? It's hugely expensive. And yet we think AI is for everybody. But when we look at these Pew Research reports, we know that there is what's called a digital divide. The digital divide is access to technology, internet access, and digital literacy, right? So it's cost for companies and cost to individuals, which is about classism. So we know that a lot of rural communities or segregated neighborhoods oftentimes don't actually have access to Wi-Fi because companies have not built in those areas, because the number of people who actually have a smartphone is not worth it for them to build a platform in that place, as well as cost to individuals. A lot of people can't afford a smartphone. A lot of people can't afford unlimited data per month, things like that. Seniors who report chronic health conditions, disability, or physical limitations that may prevent them from full utilization, that's around ageism, right? Older adults are great with smartphones. I think that there's a lot of misconceptions of like, they're an older adult, they need so much help. But sometimes those living with, again, complexities of individuals, so older adults, chronic health problems with disabilities, might have problems using smartphones, using technology. How are they going to get AI? If they have a link to their phone that's like, you know, come online and you have to check in now, are they going to know how to press that link and how to do the forward buttons? Because even though I've had years of experience with smartphones and technology, sometimes it takes a while for it to load and it's buffering, and then I just close it and think that it like got accepted and then it didn't go through, and then all these things happen, right? Technology does have issues, algorithms do have issues. And so when we think about patient-centered AI and data-driven AI, when it's about connecting to the patient, we actually have to see who is it for, again, right? And AI may have restrictions for those living with disabilities, and that's about ableism. So again, there are so many ethical benefits, and AI has helped those living with disabilities, but there have also been many frustrations and limitations and frustrations with it because it hasn't worked properly. So we think about all these amazing ways that AI can shift it, but yet what is happening at the table? And this is just a little like image that I like to explain the digital divide. I know that it's about social, economic, geographical, your approach, your culture, things like that, where all that connects to the digital divide. Like if you get something that's connected and you're a non-English speaker, right? Do they know that? Are they going to send something in Spanish? But if you don't speak Spanish or English, how are you actually going to communicate? How are you going to know that? How are you going to work with that, right? And that's about the patient-centered AI that I'm talking about, but it connects to anything else that I'm referring to. And so in kind of wrapping up, I'm not sure how much time I have or where we're at. 50? Okay, perfect, actually, because I want time for questions. So implications. We have training on public health and health equity, right? AI developers, researchers, physicians, patients need training on public health and health equity. Maybe some of you are nodding and you're like, what you're saying makes total sense, but not a lot of people know about it. Not a lot of people are aware of it, especially the AI developers at the table. They are concentrated on the algorithm, but they are not necessarily asking the public health questions. Social determinants of health conversations, the fact that people are complex, the fact that people are being left out of algorithms and biobanks and things like that. We need more diversity in bioethics. So even if I'm talking about this, bioethics was created. They're trying to change, but it was mainly a white male profession. And those theoretical ethical principles that I created, that I talked about at the forefront, were created by older white men. Like those are the philosophers, right? So we need more diversity in AI, in healthcare, and bioethics. One of the main things, and these are the last two, is community advisory boards. And what I mean by that is when AI developers are sitting at the table, thinking about their AI developments, they need to talk to researchers. They need to talk to patients. You need to talk to physicians. And that way around, you can't just do an algorithm, put it out there, and never hear back from that physician about how it actually worked, how it practically engaged. Did it build and enhance trust? Did it get those patients to uphold preventative care? Did it get them back in the healthcare world? That's what we want out of AI. This whole idea of easier workflow, earlier and faster and more accurate diagnoses is to get people healthier, right? It's to change diseases, to have people stop dying of cancer and Alzheimer's and all these horrible neurodegenerative diseases and find a cure, right? Like that is the purpose. It's beneficial, right? It's for a benefit. But yet if we leave those people out of those conversations, then there's only those specific people at the table making those decisions for everybody. And what I hope that I showed is how AI just filters one by one by one that individual person that needs that help. And then collaboration of AI with patient-centered care, right? AI can do amazing things, but what we always have to remember at the end of the day is that these are patients and we need patient-centered care. What does the patient want? What does their family want? What is actually going to help them? I want to end with something called cultural humility in medical AI. The idea of cultural humility is a bit different than cultural competence. The idea of cultural competence, which many of you have probably heard of, is this idea of gaining knowledge about somebody's culture or cross-cultural considerations. It's about reading a lot and doing research and making sure you know about it and know the questions to ask. Cultural humility is more of a long-term process about self-reflexivity and self-awareness. And that's a really hard thing to do, right? Because you got to sit there and be like, what are my biases? What are my assumptions? Have I done things that were discriminatory in the past, in the present, right? That's like really hard to do. And I imagine that AI developers and most researchers are not necessarily doing that. And so we have to develop trust, familiarity, and mutual respect, capacity building, stages and types of informed consent. So informed consent doesn't just look like that piece of paper that somebody signed. It might be verbal, it might look different. I don't know how many of you know what reading level an informed consent should be. It should be 3rd grade reading level, not 8th grade, not all that medical jargon that you often see, 3rd grade reading level. Community-based, context-specific resources. So again, going back to some of that responsibility, some of that bias, you can't just have an algorithm and then hope that it works out. What are those context-specific? What are those community advisory boards? What about dissemination practices and knowledge mobilization? How are we going to get people involved in that conversation? And the last idea is self-reflexivity, getting people to sit down and actually have these conversations at the table and bring people to those conversations. And I know what you're thinking. You're thinking patients do not want to go and sit with a bunch of AI developers and like have these conversations. That seems incredibly boring, right? But I don't think it is. I think patients would actually want to be involved in conversations regarding their health and their future family's health, their children's health, because this will impact. We're not going to stop using AI, right? AI is going to grow and grow and grow until, you know, robots are doing our surgeries and like doing things for us, right? And taking over the world. That's what all the movies have taught me about AI. But in reality, it is going to become more and more apparent. It's going to become more and more accessible. Even though I've talked about equity in health systems, as the years progress, AI will merge into community hospitals. They will become less expensive. There will be more resources for AI. Things like that will shift. And so we just always have to keep these questions in the back of our mind of who these patients are. So cultural humility is about holding systems accountable. That's not just the institution that you work for, which is the question here, but it's also keeping AI developers and researchers accountable for the fact that these are human lives that we want to make better, right? These are decisions that we are making that is impacting health. And then understanding and addressing power imbalances. AI developers have power. They have power of these algorithms. They have power of AI and creating these mobile apps and doing these things in order to ease health systems, in order to ease the burden of physicians. Are we following up with that promise? Is that promise happening? We need to ask ourselves these questions and make sure that we are using AI to the best of our abilities while still paying attention to the complexities around patient-centered care and who our patients are. I'm going to leave you with that, but I do want time for questions. That is my email address. Please feel free to email me, but I just want to open it up. Any questions that you may have, and thank you so much again.